Hello, Assalamu alaikum, and welcome to the session on Cancer Awareness Month. As you all know, we have created this program today to create awareness amongst all the people for this very special and very important month. We are very happy that we have a very good panel today, and we will be discussing cancer, the types, and what are the conditions and how to prevent them, the screening methods. Before I officially start and introduce you to my panel, I would also like to tell you that we are very fortunate that just with the beginning of this year, we were very fortunate that our MD of Prime Healthcare Group had announced something very major during the Arab Health Week. And we at Prime are always on the front foot. I am sure that you'll be very happy and very pleased to know that Prime has launched a program, and they are coming with a hospital which will be a very up to the mark, and extremely professional, a very good center of excellence in lung, heart, and oncology. This hospital will be coming up in the next few years, and we are very happy that we can provide these services. And inshallah, we pray that we will be the leaders in healthcare in the region and globally, inshallah, someday. With this, I would now move on to the panel. I would like to introduce a very dynamic team of my physicians today. We have incorporated multi-specialty here because a lot of people come from different backgrounds with different questions. We will cater to the gynecology. We will cater to the specific breast and surgical conditions. We have a gastroenterologist on board. And last but not the least, we have our hematologist, oncologist, a doctor as well. So without further ado, I would first like to introduce Dr. Arun Karanwal, who is our specialist oncologist, hematologist. He's an extremely capable oncologist. To date, he's seen a lot of cases. He's treated a lot of them, and we are very happy and proud to have him on board today. Welcome, Dr. Arun Karanwal.
Thank you, Dr. Ahmad.
You're welcome. Second panelist we have is our consultant gynecologist obstetrician specialty with surgical and laparoscopic procedures. We have our consultant, Dr. Qasim Azaz. He is an extremely dynamic surgeon, obstetrician, gynecologist, and we are happy to have him today. Dr. Qasim, welcome to the program. Dr. Qasim, can you hear me?
Yes, I can hear you. I say thank you.
Great, sorry. Welcome to the program. Doctor, from the surgical team, we have a breast surgeon, our general surgeon, and breast surgeon with special interest in surgical oncology. A lot of publications. She's very enthusiastic, very friendly, very popular. I would like to introduce Dr. Virishka Mansakhani, who will be joining us today on this panel.
Thank you, Dr. Hamal. Welcome, everyone.
And last but not the least, one of our phone doctors. You have seen her numerous times on these webinars. She's very energetic. She speaks really well. She's very approachable to patients. And I would, without further ado, Dr. Fatma, welcome to the program again. I think you're on mute, Dr. Fatma.
Oh, yes, hello. I'm happy to join you again.
Thank you. So I would start this talk today with Dr. Arun Karanwal. Dr. Arun, would you briefly tell us about this Cancer Awareness Month, and what is the importance and significance of this month, please?
So, as you rightly mentioned, that this is very important month for the oncology field, and 4th of the February of each of the year, we have this awareness event, or the awareness day, or you can say the full month is dedicated for the awareness of this disease. It's called World Cancer Day, and the idea behind of this kind of event is to increase the awareness or the information of this kind of disease regarding its prevention, regarding its reason behind such kind of disease, regarding its treatment options available, the diagnostic things available, so that more and more people can take help of the medical facilities to help to cure this kind of disease. That is the idea behind of doing World Cancer Day awareness events, and it is generally supported by most the international oncology societies, and worldwide there are different events happening on this month.
Thank you, Dr. Arun. Dr. Arun,
Yeah.
cancer is the word cancer, the name. When you hear cancer, this is very frightening. It is end of life. That's what I experienced. That's what I saw. A lot of people, when you explain to someone and when you tell them you have cancer, what is your take on cancer? What is cancer to a layman? What is cancer, and what are the types of cancer in this diseases group?
So first of all, I would like to just highlight that it is not a cancer word is not a end of life, and we are living in 21st century where we have so much advanced treatment available for such disease, and we are seeing so many patients who are getting cured every year from this disease. Definitely, it is a scary word, and still there's a very misinformation or myths regarding the cancer disease. It is not a single kind of disease. It is a very heterogeneous group of disease which can involve any part of the body. There can be different variety of tumors which we can see. Generally, we divide the tumors into solid tumors, solid organ tumors, or the blood-related tumors. In the solid tumors, we can see commonly the organs like breast tumor, the colon tumors, lung tumor, prostate cancer, and sarcomas. In the hematological or the blood-related tumors, we can see acute leukemias, chronic leukemia, which are typically the blood cancer, which we say, and sometimes lymphomas are there and myeloma. So there are lots of different variety of tumors, and each is very different in the care plan, in the available option of treatment, and the chances of cure. So in general, we should not say that it is a end of life, because now most of the tumors will be having lots of good option of treatment, and there is a significant chances that it can be cured.
Great. This is very refreshing and very reassuring for us, because uh, when patients with cancer usually are very sad and depressed, and the family gets extremely worried. They get very, very depressed. So as you rightfully said, that now the options have increased, and especially at Prime Group, we're having with these all of you in the panel, and plus other facilities. We think we have moved into we've taken a step ahead, and God willing, we will be able to cure these conditions. Thank you for that response. It actually eases off, and it makes us a little comfortable that it is no more an end of life. Dr. Qasim, uh, cancer in women. I'll be more precise. What is cervical cancer? Because these are the types of cancer we hear about when women speak. So, in your opinion, as an expert, what is cervical cancer, and what would be the symptoms of cervical cancer? And if you don't mind, I would also like to know if you could share the prevalence in this region based on your experience.
Yes, hi, good afternoon, everyone. The cervix is the lower part of the uterus. It's actually the part that connects the uterus to the vagina. Cervical cancer, that's mean that when the normal cells in the cervix became abnormal, and the growth is going abnormal growth. So this is the meaning of cervical cancer. The prevalence in the area, actually, there is a lot of there is no official statistics about the prevalence of cervical cancer in UAE. But actually, we are seeing these cases like more frequently these days because of the lack of the awareness, especially of the screening programs, and also the vaccination, which is available to prevent the cervical cancer.
Thank you. Thank you. Thank you. That helps. Thank you very much. To all the viewers, I would like to welcome you because we are going live on LinkedIn as well. And we are very fortunate that people are very, very active, and they've actually reached out to us and they've sent us a lot of questions. I will be moving on to the questions, but before that, I would like to just move to the other two panelists just to get an intro on their specialty. Dr. Virishka, breast is a very important part of the body, be it male or female. Uh, breast surgery, breast cancer is associated with women. Do you think, I would like your take, so if you could tell us more about breast cancer in particular, but we have a lot of male audience, and I personally have seen I've seen patients that walked in and they complain of lumps in the breast or the chest area. So would you say that men can also get breast cancer, and especially about women cancer, because that's one of the most important things. So breast cancer in women, if you could just elaborate and tell us more about it, please.
Yes, Dr. Hamad, it's a really interesting question because, yes, in the male population, we have 1% of the male population developing breast cancer. I have had the sad privilege to treat one male with breast cancer. It's as aggressive as the female gender, but of course, it can be treated if it's picked up early. Men also develop lumps in the breast, but please note that is what they call just a hyperactive glandular involvement or enlargement, which is called gynecomastia. That should not be confused with a breast lump per se. So that's what we have to differentiate before. So we can, even when a male patient comes with an ultrasound breast, we can identify just by looking at the ultrasound that yes, it is only because of gynecomastia. That means enlargement of the male breast and a unhealthy lump. In females, the sad thing is it's now the leading cause of breast of cancer in women. It has superseded cervical cancer. As Dr. Qasim said, yes, if people are aware, they can take the vaccine and reduce the risk. So we have tried to reduce the risk for cervical, but for breast right now, we don't have any vaccination or any medication to stop it from forming. Any lump in the breast should be treated either knowing the diagnosis, whether it's malignant or benign. The screening we would be going through, I'm sure, later on. But the increased incidence is 1 in 8 women in their lifespan will develop breast cancer. Every 13 minutes that we are talking, sadly we are diagnosing one woman in the world with breast cancer, and every 8 minutes that we've already spoken, we are losing one patient to breast cancer in the world. So as we can see, it's really a very aggressive tumor. It's very common, and we don't know the cause. Thank you, Dr. Hamad.
Wow, this is interesting. These statistics are mind-boggling, Dr. Virishka. If we have mothers, sisters, our family members, female family members, we have to take this seriously because, as you rightfully said, we have to start taking our health very serious. Cancer has become so prevalent these days. I remember back in the day, you would hear about someone dying of cancer or diagnosed with cancer, but it wouldn't be as common as it is now. So yes, it has, and I will be coming to the part where you will be telling us more about the screening processes. But thank you for that information. Dr. Fatma, question for you would be, uh, a lot of people have very poor dietary habits, or they have a lot of gastrointestinal complaints. Does that mean a colon cancer can develop in these patients? What would be the alarming symptoms of cancer colon? So what would you identify in the stomach area or in the abdomen for a patient with cancer?
First of all, I want just to take the chance of this webinar to announce that the coming month, which will be in March, it will be the National Day Awareness, Month of Awareness about colorectal cancer. So this webinar give me an introduction to a very important issue, which will be covered next month in all national, all over the world. Colon cancer, actually, it's one of the most important cancers would like to cover in gastroenterology.
because it has a very important significance in regarding mortality. It's the third most common cause of mortality in females and the second most common cause of mortality in males. Usually, we face lots of scenarios in our clinics coming where they have confusion in their symptoms and they have lots of stress. Do I have cancer, doctor, because I have such symptoms and I saw such thing? Always, we stress in the aware our patients regarding the thing called alarming signs in the presentation. This is one thing. The alarming signs we look about it is altered bowel habits, sudden change in bowel habits, and the bleeding per rectum, which accounts for most of the causes. About 75% of cases with colon cancer, they will present with such a complaint. Other symptoms that are a little bit tricky, and it lies on the burden of a doctor to discover them. And this here's come the importance of good clinical examination and history taking, like on and off melena or unexplained iron deficiency anemia for a long time. It's one of the presentation of a colon cancer, hidden colon cancer. Also, abdominal pain associated with weight loss, all are alarming symptoms. But not always we rely on alarming symptoms alone. Other factors which are important to look for when we are looking for high risk populations. And here comes the role of genetics and family history. So we always, whenever we are assessing a patient about the possibility of having a colon cancer, all these factors comes together: the clinical presentation, the genetics possibility, and the family history. Some of them are modifiable, like lifestyle, as you asked me about dietary lifestyles, sedentary lifestyles. These are modifiable, but there are other non-modifiable factors, which is genetics and family history.
Right. Thank you. Dr. Arun, if we take this fact, which is genetics is one of the direct causes, or I would say risk factor to develop cancer, is there any way to prevent this? Do you think, like we say, prevention is better than cure? Can we say that about cancer? Because if genetics are involved, do we in modern science, as an oncologist, do you have any information that you can share with us? Can you elaborate this part to prevent it?
So in general, most of the tumor development is based on the DNA changes, the mutation or the errors in the DNA. Our body is very complicated like thing, and our cells are regularly developing. They are monitored by our immune system. Whenever these new tissues is forming, there's some risk of getting error in the DNA, and these errors are detected by the immune system. Whenever the immune system is not able to detect such kind of errors and it is not possible to repair, there is a chance that these abnormal cells can become a cancerous cells. So in general, all the tumors are related to changes in the DNA. How it is important to know that or remember that 90% of this DNA changes are not linked to hereditary transmission. Means it is not a change which is passing from the family generation. It is the change which has happened in that person's own life, and it will not pass on to the further generation. Only 10 to 15% maximum cases of tumors are related to the hereditary or genetic germline mutation, which can pass on to the other family members also. So, the risk factors which we are seeing in our general practice for the tumor development, as rightly said by Dr. Fatima, that it can be modifiable risk factors which are commonly linked to our lifestyle changes. We are seeing so much significant changes in the lifestyle in the last 40-50 years, that there's a significant change in our dietary habits. We are going more towards processed food, more towards junk food. We are relying less on the natural foods. We are having more and more sedentary lifestyle, less physical activity, more and more incidence of smoking, alcohol. These all are modifiable risk factors which are increasing the chance that some of the normal body tissues can convert into the cancer cells. There are certain definitely non-modifiable risk factor, as I told, germline mutations, which can also increase the risk of central tumors. So based on this risk factor, we can think what can be the preventable reasons, what can be the preventable actions to prevent cancer. So if we modify these bad habits like the lifestyle changes, we go towards more of a natural food, we increase our physical activity, we reduce the chances of or reduce the intake of alcohol, try to avoid smoking or completely stop the smoking, then definitely we are significantly improving our chance of preventing such disease. And definitely there are other important things like now there are certain vaccines which are available to prevent such kind of tumor, particularly for the cervical tumor. We have very good and effective HPV vaccine. Same thing applies for the hepatocellular carcinoma or the liver cancer, which is sometimes related to the hepatitis B infection, and we have the very good hepatitis B vaccination available for it. So these are the two good vaccines available for prevention. And third is the screening or screening methods, which are basically based on the principle that if we try to detect the cancer in the early phase or in the pre-malignant scenario, then there is a very good chance of completely curing such disease. So based on these like lifestyle changes, screening methods, and the vaccination, we can try to reduce the incidence of diseases.
Okay, okay, that is good to hear. Dr. Qasim, is there a rule of thumb, or is it common? I mean, of course, you see that in your practice. I have a circle of people that I've known, especially young females or females. Is it common to have someone come to you and a female and says, I want to be tested for cervical cancer because my mother or my aunt or my sister had cervical cancer? How is that related? And how would you test for this cervical cancers? And as they mentioned, there is a HPV vaccine. Can you please tell the viewers, listeners, all of us, how effective is the vaccine? Can you say that if you take the vaccine, you don't get cancer?
First of all, sure, some patients who have awareness, or like you said, if they have history in the family for a cervical cancer and they know about the screening process, they came and they ask for the process. And some of them actually they came to screen even if they don't have history, but still these people are low, and we need to implement actually a campaign in all the area to spread the awareness about the importance of cervical cancer screening, because it's really easy to screen, easy to detect. Also, it will make the survival rate better, and also it's preventable by the HPV vaccine. First of all, I want to say here that human papilloma virus is responsible for 99.9 almost percent of the cervical cancer. Not only the cervical cancer, also the human papilloma virus, if it is in the cervix, it will cause the cervical cancer. If it was around the anus, it will give also anal cancer. Even it can cause mouth or throat cancer if it affects this area. So using the HPV vaccine, it will decrease the risk of all of these three cancers in these three areas. Of course, it's not 100% effective because we have more than 100 type of human papilloma virus. Some of them are low risk and some of them are high risk. The vaccine which is available in the United Arab Emirates is the Gardasil 9, which contains 9 types of human papilloma virus. And these types are almost responsible for more than 70 to 80% of the cervical cancer. So taking this vaccine, it will decrease the risk of cervical cancer significantly. It is important to, like I said, spread the awareness about this vaccine and its effectiveness and its safety. And also it can be given for both male and female. But if we focus on the female, it can be given from year 9 to year 26, until age 26. Usually, the physicians prefer to give it before 15 years old, because at this time you need only 2 doses. After 15 years, you need 3 doses. Usually national, for example, in UK, the national program giving this vaccine on year 11 or year 12. So it's like grade 8 or grade 9 in the school. Implementing this, like I said, in the country, it will help decrease the risk of the cervical cancer. And of course, the survival rate also will be better.
Dr. Qasim, I have a concern here now. When you say it is caused 99.9% by a virus, now I think of two things at this point. One, is it contagious? If it is a virus, viruses are contagious. That is what the human mindset has become all about, especially COVID and influenza and viruses. So first part of my question is HPV, is it contagious?
HPV is a sexual transmitted disease. So that means it will be transmitted during sexual intercourse of this. So it is contagious, but the way of transmission is sexual intercourse. So of course, if someone has multiple partners, that's why if there is safe sex is also a way to prevent cervical cancer. Using condom during sexual intercourse, it is a way to prevent it, because you will prevent the infection. So sure, it is contagious. But the way
why would you make it, if it is passed by a virus, and if it is a condition caused by a virus and it is contagious, why is it turned into cancer? Why not into a normal sexually transmitted disease? Why don't we call it as an infection rather than cancer? Where does the cancer come in with HPV?
Yes.
So when it affects the cervical area in the uterus, how does it grow? Does it actually spread? Do they have metastasis? Do they have grade stages?
Sure. The infection with the human papillomavirus, it will increase the risk of having a cervical cancer. That doesn't mean that if you have this human papillomavirus, so for sure you will have cancer. Like when you are saying for lung cancer, if you are smoking, the lung cancer will be more. So the rate for you to have lung cancer if you are smoking, it's increasing. But in the cervical area, the only risk factor which have been implemented, and which, like I told you, it's like responsible for 99.9% of cervical cancer, which is the squamous cell carcinoma. This is one type of the cervical cancer, which is 100% done by the human papillomavirus. So not all the human papillomavirus, like I told you, will cause the cancer. There is low risk types and there is high risk types. Getting infected with this with this virus, it will increase the risk because of the changes which will happen in the cervical cells, and the mutation which could be happen after the infection. This is the risk which will happen. Doesn't mean that if you have the infection, so 100% you will have the cancer. No, this is not the situation.
So in these patients, you detect the virus? You do in our Prime Hospital in your gynae practice. So are you advising patients? What do they look for? What are the signs they look for to come to you and say, you know what, doctor, maybe I think I have cervical cancer? Because you're talking about a contagious, transmissible cancer, form of cancer.
Get infection with human papillomavirus most of the time, if it didn't cause symptoms, especially in the cervix. If it is in the genital area, it will cause this condyloma. But if it is in the cervical only, on the cervix, so sometimes or most of the time, the patient doesn't have symptoms. Even cervical cancer itself, some patient will have only abnormal vaginal bleeding. Sometimes only she will tell, I have some bleeding after intercourse, or only in abnormal time during my period. And this is not the time that I have bleeding. Then you will do the examination, you will find the mass, or you find the cancer itself. But we are speaking about the screening, which is before any lesion became a cancer. So during the screening, the doctor will have, usually we are doing BAP test, which is a fluid we are taking from the cervix itself, from the canal of the cervix itself. This fluid will contain cells from the cervix, and also we can do the test for the human papillomavirus. And this double test together will give you the screening thing about the cervical cancer. So
Great.
during the screening, the doctor will collect the fluid from the cervix, and we will send for histopathology for the pathologist to check if there is any abnormal cells. Pre-cancer, we are calling this pre-cancer lesion. So if you discover it and treat it early, it will not develop to a cancer. And also we'll screen for human papillomavirus. And this human papillomavirus, we will see is it high risk or low risk human papillomavirus the patient has with the
Great.
screen.
So as you said, this is more of a silent form. So
Yes.
this is why I think why you are advising that all women, age-bearing women, young and old, or sexually active, or young females,
Yes.
should come and get screening done with us at Prime Hospital. And we'll be sending down a roller so all our viewers can view it on the screen. We have the services available in Prime Center, Prime Medical, entire Prime Healthcare Group. We are very fortunate that we have these facilities here. So I request all women that are concerned, that have any doubts, to always, when you are in doubt, you shout. So this is very good information, and then
Yeah,
it
yes.
does help.
Yes,
Absolutely.
I want to say that maybe the patients will ask how I know that if I need a screening for cervical cancer. The screening program should start from 21 years until 65. And usually it's done every 3 to 5 years according to what type of test we are doing. Either it's only Pap test or it's Pap test with HPV testing. And of course, there is some patient will have different type of screening if they have lesion or any abnormality have been found during the screening. So any patient which is sexually active, she should counsel her doctor about the cervical
Absolutely.
cancer screening, and if possible also about the human papillomavirus.
And of course, we have that facility in Prime Hospital or Prime Healthcare Group,
Yes.
because so this way we can create awareness and let them know that they can proceed with the test. Moving on, Dr. Virishka, breast lumps, some are accidental, some are observed, some are ignored. At what age should females be concerned about breast cancer, and what are the high risk patients, and how do they identify it? When do they know that they have to come to you?
So let's start the screening. So we have as a low risk and a high risk group. The low risk means they don't have any family history or genetic makeup in the family, either for breast, ovarian, or uterine cancers. Those come as the low risk group. The high risk group, of course, all the genetic factors, mutations, along with family history, very strong family history of first, second, and third degree. Also, with very high risk factors would include unhealthy lifestyle, alcohol, smoking, those who are taking the hormone replacement therapies, not oral contraceptive pills. Please note, oral contraceptive pills will not cause breast cancer. It is the
Thank you for clarifying this.
hormone replacement treatments which cause breast cancer. What is that? Especially those women post-menopause who would like to take medication to continue to stop the post-menopausal syndrome, to stop the aging process, to stop the skin laxity. Those have to be curtailed a bit and be advised by their doctor that it's not a very good decision to make for a long-term process. Then we have women who are single, unmarried, above the age of 40, with no children, also a little bit a high risk group. Non-breastfeeding mothers, also high risk group. A bad obstetric history with multiple miscarriages, abortions, also considered as high risk. We have other unknown factors which we don't know, which is a question mark. So that's why everybody would come for screening, especially the women. High risk group come 10 years before their relative was diagnosed with breast cancer. Women, otherwise in general, have to come for screening from the age of 26 and above. We're also started to screen women even younger at the age of 20 and below Why? Because we're seeing younger population with breast lumps. Please note, 50 to 60% of women will develop breast lumps. And out of that, 80% are the benign breast disease, means non-cancerous lumps. So we screen them whether you have symptoms or you don't to pick it up early. We utilize 3 techniques. The self-examination, where we teach the patient how to do a breast self-examination. We have where they come to the doctor, either the gynecologist or the surgeon. If it's to the gynecologist, they will examine. They will do the investigations, refer to the surgeon. We will also clinically examine the breast and the armpits. We will do an ultrasound with or without an MRI, with or without a mammogram. Initially, it was decided only mammogram, but now we've also coupled it with ultrasound for the younger population.
Great, great. You know, Dr. Virishka, we live in a country or a region, I could say, where talking about breast and talking about these parts is a social taboo. Women are scared. They feel that they could be deformed. They feel that the lump would be removed and there would be a very there will be the shape is deformed primarily, and it's more of an aesthetic reason. It's more about a culture. It's the way a woman perceives herself. So a lot of women are actually scared to come forward. What would be your message? How would you tell them that it's okay to come and see you to get it checked? Because that's the sad part, that a lot of cases when they present to you, end of the day, very less can be done. So early detection. What would be your message to these women?
My message to the women would be, kindly do come for screening. We are available where even if you do find a lump, as I said, 90% are the benign or the lumps where we can keep you on follow-up. The ones which start growing in size will deform the shape of the breast. Younger you get it, the chance of developing these lumps could increase. But coming to be screened before it forms a very huge lump or not even palpable lump, if we find a small lump, even if it's 1 centimeter, still we'd be able to save the breast. If it becomes as a malignant tumor or a cancerous tumor, we don't have to remove the breast completely. As Dr. Arun and me, we are treating patients without doing a complete removal of the breast. We are doing conserving breast tissue. Even if we do need to remove the breast, we have cosmetic surgeons. We have a plastic surgeon available with us who's also in our team to help reconstruct the breast tissue. As we know, for women, it is like an amputation if we do a mastectomy. But of course, now we don't do these radical techniques if the criteria fits to save the breast or to do reconstructions.
Thank you. Thank you for clarifying this part, because I personally have known people here, women with a lump, and again, same thought process. No, maybe they will remove my breast. No, this is not fair. So thank you for clarifying that you have a team, and it's so important for us to know. And all my viewers today on the show, we are so happy to hear this. It's very important for us to know that you and Dr. Arun and Dr. Qasim and all our team, we are well equipped. Prime Hospital is fully equipped with all subspecialties to back you up. So I am sure, and I really hope that all our viewers today, if there are women sitting in the back seat that do have some sort of doubts about their bodies, please, I request you that this is a whole month. We have very capable oncosurgeons, oncologists. Dr. Virishka herself is a surgeon and oncosurgeon, so she helps specifically with breast masses. So again, I would request all of you, and this was very refreshing for us, Dr. Virishka. Thank you for that part. Dr. Fatma, moving on to you. Colon cancer, again, a bit uncomfortable, a bit shameful. It is a little embarrassing that I'm bleeding per rectum, but I'm not going to the doctor because I don't feel comfortable with this. So how do you screen colon cancers, and what are your methods available with us, and how would you tell our patients to come and follow up with you? What is your take on that?
Okay, first of all, I want just to clarify the definition of screening. Screening means enrollment of a programmed evaluation. this evaluation, the target of it to detect colon cancer before it is fully developing, yani before in the earliest stages. So most of these cases, actually, they are asymptomatic. They come to us with no symptoms, but we are, as doctors, we have to categorize them according to the risk, as Dr. Virishka previously explained, to categorize them in which risk groups. Either they will fall in average risk group or high risk group. This is if we are talking about screening, it means that before developing bleeding per rectum or any other symptoms, which is the target of our webinar, which is a preventive medicine, to prevent the disease before it is happening. This is the main burden on the gastroenterologist. The higher the detection rate of these cases, it will be really an achievement, because it will reduce the mortality and the prognosis and the incidence of the colorectal cancer before any of the symptoms occurring. In our mind, usually according to the guidelines and the recommendations, we categorize people according to many risk factors. Usually, the average risk factors, as Dr. Virishka before explained, I will try to explain it as simple as possible so that our audience will feel it is easier to their mind. The average risk people is any one of us, ranging by age from 50 to 78, or let's say 80, okay, and would have no genetics predisposition. These are average risk group. This group of people, they should start screening, which is looking for early possibility of having the chance of colorectal cancer starting from age of 50. So this is our first group. The second group, which lies under the high risk group, here other factors will enter in this to modify the recommendations and adjust the recommendations, which is family history, means genetics, family history, which may be non-syndromic, genetic predisposition to have this cancer, okay? And in this entity, we always ask a patient, do you have any family member that got as cancer, first degree relative, especially below 50 years, or more than one first degree relatives? If the answer was yes, then I have to lay stress more to confirm that yes, this patient may have a familial predisposition to have colorectal cancer, and he should be involved under screening categorized as high risk. Other peoples, they have genetically inherited syndromes, which are very less than the genetic predisposition or the family risk of having a cancer. Two entities, syndromic and non-syndromic. The non-syndromic is the family predisposition, the more common. The syndromic, these are a little, and the most common are, I don't want to enter in such scientific names like familial polyposis or Lynch syndrome. These categories, by history, we can know them by having more than one person and more than one generation having extra colon cancers. These will be categorized under another entity, and they will start screening before the ages of average risk. So at each population, there is a starting age of screening according if they have the risk factors we already talked about. But all over, the average risk, we start at 50. The high risk, if there is family history, we will take the number of the first degree relatives, the age, and usually we start at the age of 40 years or 10 years before the youngest member, and then the frequency depends upon the age of the first degree relatives.
Is it the same, Doc? Is it the same for gastric cancer versus colon cancer?
No, it is different.
Okay. All right. Okay.
Regarding the colon cancer, I want just to clarify one simple thing to make the idea of the whole concept easier to the audience. I want just the audience to imagine the concept of developing a colon cancer. It starts with simple changes of the inside wall of the colon. Cells start to accumulate together and start to acquire certain benign changes. It's called adenoma. This adenoma, it will increase by size to form a polyp, and this polyp, by time, it will acquire neoplastic or cancerous criteria, which will form later on a well-blown cancer. So our target is to discover the first step to prevent the progress to the cancer.
Great, thank you, thank you. That was very elaborative. And just a short answer on this. So you do screenings in the clinics, because we want our. There's a lot of people that are concerned that might want to visit you and do these screenings for CA colon.
Of course,
So,
screening
okay.
for colon cancer has many modalities. Each modality, it has a certain specificity and sensitivity. There are some tests we can do it in the stool to detect the early presence of cancer with a good sensitivity and specificity, like occult blood in stool. Also, we have the procedure which is called colonoscopy, which is the examination of the whole colon by using a fiber optic scope. At the tip of it, there is attached a camera and the light. I examine the whole colon, the whole segments of the colon, to detect the early presence of the adenoma, which I already spoke about, or a polyp, and it should be removed during the procedure. Also, other choices for people not willing to go for colonoscopy, there is something called CT scan colonography, which also give a good yield. But also for each modality, we have to explain to the patient how much it can detect the early cancer and how much it cannot, because for each one it has a limitation. After all, we are targeting early cancer, not detecting the cancer itself.
Right, right, absolutely. We have received a lot of questions, and it's so overwhelming, and it's interesting because we have people that are seeking answers from the experts. You guys have been so to the point and so elaborative. Thank you for this information. My question and answers, I'll probably start because we are running out of time, but we have a lot of questions. There's some very interesting questions here. This question I probably would put to Dr. Arun Karanwal. Mr. Anirban Das Gupta has said that cancer have the root from the amino acid. Fascinating with protein cell disaster. I didn't get the question right, but probably he's trying he's trying to incorporate proteins with cancer. Is there any relation between proteins and cancers, or specific proteins that are found? Because I'm just.
Yes, so as I mentioned in the previous talk also, that in general the underlying pathogenesis of the cancer is to have a changes in our DNA, which can be because of multiple reasons. Now, any change in the DNA will ultimately also affect some of the proteins which are important for the regulation of the normal human body cells or the tissues. Whenever there is a defect in some of the pathways of the proteins because of these DNA errors, these kind of errors will ultimately increase the chance that the cell become autonomous. It will grow out of control and ultimately be called as a cancer cell. So definitely there is changes in the proteins also, but overall we cannot say that there is a specific protein which has to be affected for all the cancers to be as a reason. It is very complicated disease, and we cannot blame any specific DNA change or any specific protein for all the cancers in our body. Each cancer, or even a single type of cancer in 100 patients, all 100 will have a different type of changes in their tumor cells. Some may be linked to certain specific proteins, some will be linked to other type of proteins. So it is
Great.
like single protein will not be a reason behind every cancer.
It would not. It would not. Perfect. That answers the question. Dr. Qasim, I have a question for you. Your surgeries are minimally invasive. You do laparoscopic surgeries for cervical cancers. We have one of our a member of the audience has asked, what are the complications of these surgeries if there is intervention or it becomes more invasive? And do you consider AI surgical support? Even in your practice, have you incorporated artificial intelligence? Is there any role?
Actually, until now, there is no artificial intelligence in surgeries. Anyway, yes, like you said, minimal invasive surgery is like evolving more and more, and now robotic surgery, if you can call it one of the AI, because robotic surgery is more precise,
Absolutely.
with less complication, but of course more expensive.
Are there any specific complications when you do these invasive procedures?
Sure. Cervical cancer surgery, according to the spread of the cancer, you can say the stage. If you are because any cancer has been 4 stages. The stage is prescribing how far the cancer has been spread. The meaning of how far we are speaking about cervical cancer. That's mean how far from this organ the cancer has been spread. So early stages of cervical cancer can be treated by surgery, conservative surgery sometimes, or radical surgery by removing the uterus and the surrounding tissue around it. But in the last stages, unfortunately, surgery has no rule because the rule will be for the radiotherapy and chemotherapy. During the surgery, the most important complication is the injury of the surrounding organs. For example, the bladder, the bowel, or the ureter. Ureter is the tube that connects the kidney to the bladder. This complication could happen, can be managed, of course, during the surgery. Of course, bleeding, infection, like any other surgery, but the most important or most dangerous complication is the organs injury. And if discovered during the surgery, actually, and treated, of course, the result will be better.
Great. Dr. Virishka, I have a question for you. We have someone who's asked, what are the measures taken for breastfeeding women? As the radiology scans may not distinguish between mammary glands and lumps at this point, so what are the frequent issues in misdiagnosis? Are there any?
Okay, so good question. Breast lumps look very different from mammary gland lumps. An ultrasound will be able to detect the difference between, if it's as per the radiologist, a good breast radiologist will be able to distinguish a mammary gland lump and a lump other than a mammary gland lump. In breastfeeding women and lactating, that is the lactating mothers, very important, if they feel a lump, they need to come to the surgeon to be examined. We will be able to distinguish even clinically if that lump is a mammary duct, like a glandular lump with milk, or is it a lump with a solid tumor or a cyst, which is actually another breast lump. Most of the lumps in pregnant women and breastfeeding mothers are high alert because mostly those lumps which are not mammary gland lumps are the cancerous lumps. So we find pregnant women, lactating mothers with breast lumps, which are mostly the cancerous ones. So please note, any woman who's lactating has to come to the gynecologist, has to do an ultrasound, has to be seen by a surgeon because these are the dangerous ones. Thank you.
Thank you. Thank you. Dr. Fatma, I have a question for you. My question to you is, it's just so many questions. What are the tools of colonoscopy, Dr. Fatma? And is it a day procedure? Is it like in and out, or do we come prepared and we stay over? And how quick can we get done with this?
I like this question. Always I explain it to my patients because always they are scared about doing a colonoscopy. A colonoscopy, it's an easy procedure. It is safe, and yes, we need to be prepared because the colon it's full of stool inside the colon. So to have the higher detection rate, especially in screening, we need the colon to be well prepared, which means that to be washed stool inside so that I can see clearly the wall and detect early lesions. Colonoscopy, it can be done by two ways. Either it is a day case. This means that the patient will be admitted. He will be under sedation, but the type of sedation which is appropriate to the procedure. It's not like that of the major operations like what Dr. Virishka and Dr. Ahmad do. It's only sedation by intravenous injection and together observed by an anesthesia doctor. We usually refer to this option, especially if patient is extremely anxious and he doesn't want to observe the procedure. But many patients, they are willing to do it as outpatient with mild sedation. And also it is not painful, a little bit annoying sometimes, but it is not painful and safe procedure, well tolerated. I can't hear you.
Hello, can you hear me?
Now I can hear you, yes.
Thank you, Dr. Fatma. So patients should be less anxious, and it's probably an in-hour procedure, so it wouldn't be as bad. So we can promote this. Dr. Arun, my next question for you is, what are the facilities available with us regarding treatments of cancer, and how well are we doing it in comparison to the other centers around us?
So I will start from the screening or the early diagnosis of cancer, as rightly mentioned by all our other speakers, that we have the facilities for screening of most important or the most common tumors which are based on the guidelines. And we have screening for the breast tumors, we have screening for the colon, cervical tumors, lung tumors can also be screened with the help of a low-dose CT scan as per the guidelines, and also the prostate cancer, which can be screened with the help of a PSA blood testing. So screening can be easily done in our center. Other than that, once it is suspected or there is a possible diagnosis of tumor, we as a multidisciplinary department try to finalize what can be the evaluation plan for this patient, like what type of tests are required for reaching to a complete diagnosis and staging of this disease. And after the diagnosis, what can be the best possible treatment option for such patient. So at this point of time, the guideline says that every patient require a multidisciplinary type of care plan, which may include surgery, which may include treatment with the chemotherapy, which is called medicines, and which may also sometimes include other type of treatment like radiotherapy. So it is generally a multidisciplinary approach, and we have these all facilities. We have good surgeons available who are dealing with most common areas of tumor, and the medical oncology part is covered by me. We have facility for giving all type of chemotherapy. We are monitoring this kind of important treatment, all kind of oral new forms of therapy like the targeted therapy, oral tablets, or some new forms of treatment like immunotherapy can also be managed. We are regularly doing this kind of treatment in our center. And regarding the third modality of treatment called radiotherapy, we have tie-up with different other centers where the patients can take and complete this treatment without much issues. So, and good thing is that in UAE, the government is supporting the treatment of cancer, and including the insurance companies. All the insurance companies are giving like a good support for whatever the necessary treatment which is recommended by the guidelines. So all the patients who are having this disease can easily take the treatment in this country.
This is a very proud moment for Prime Healthcare today, as we stand in this global market or in this community, that we are well equipped and we have the facilities and we have all of you, all experts. Prime has always wished people in the community to be healthy. We promote health awareness, we promote healthy lifestyles, but we also want all of you to know that if you need any help with your health, right now we're discussing cancer, but on all other notes, Prime Healthcare Group has taken it to another level, and this is a very proud moment for all of us. And we wish that we can always be these best, the best service providers in healthcare industry, inshallah. A quick question to Dr. Time is running out. I wish we could have spent more time on this, but we have restrictions. My next two questions is first one for Dr. Qasim. Thank you for explaining the procedure of the pap smear. Just a quick answer. How long does the procedure take? Is it an in-out procedure? Dr. Qasim is gone. I think Dr. Qasim, can you hear me?
Yes,
Dr.
yes.
Qasim, can you hear me? Right. I said thank you for explaining the procedure of pap smear, but the only concern right now, if you could just briefly tell us, is this an in-out procedure? How long does it take for a woman to come and get a pap smear?
Usually the procedure will take less than 5 minutes.
Oh, fantastic.
It's like you said, it's an in-out procedure. The physician or the gynecologist will do a vaginal examination with an instrument, we call it the speculum, to open the vagina, reach the cervix. A brush will be used to collect the cells from the cervix and the internal canal of the cervix, and it will be put in a container and sent for the laboratory to complete the procedure. So the procedure itself, it's less than 5 minutes.
Oh, okay, perfect. So a lot of women can now be at peace because but there is always a confusion that this is a procedure. We go to the hospital, it takes long. So thank you for telling us this. Moving on, Dr. Virishka, breast masses. How long would a female require to come to you, and how long is this procedure of doing the biopsy or other procedures related to diagnosis of this cancer in the breast?
So for the only procedure that would be done, which is invasive, minimally invasive, is the biopsy. We have two ways of doing it. Depends on how many lumps that we would need to biopsy. It's normally done more accurately with an ultrasound guidance. And the procedure, once we have the biopsy, it's less than 2 to 3 minutes. We give local anesthesia. We take out the tissue that we need for sampling, and we send it to the lab. It's, as we said, it's an outpatient procedure. It's done in the radiology department by me as a surgeon, and we decide which lesion, depends on how deep it is. Sometimes just to locate the lump, if it's very deep, only that's a technical issue, which can take a little more than 5 minutes.
Okay, interesting. So all our screening methods at Prime is just an in-out procedure. And I hope that after today, we can spread this message to all the people who are listening to us today, that these procedures are simple procedures now. Science is so advanced. We at Prime are so advanced that the procedures are short, quick, in, out. It can save your life. It can save a lot of time, a lot of resources. So I request everyone, if we have our details, we have our website, we have all the data information available on these websites. They can contact these doctors, take appointments with them. We'll be sending out information about our panel today. And if you would like to have private consultations, you can just book and see these clinicians. I would like to thank each and every member here because, of course, in general, all doctors are important. Every doctor is blessed. But what Dr. Arun and Dr. Qasim, Dr. Virishka, Dr. Fatma, these specific cancer-related issues, they are very sensitive. They are very emotional. So I would like to thank you on behalf of everyone in our group and all your other colleagues who are dealing with the same conditions, who unfortunately can't be on the show today. But I would sincerely thank you for your great work and the number of people that I could actually say you have saved or made them happy or relieved or taken care of them. So I would like to thank you for that, and I wish that we are entering a stage where we could say that cancer is a disease of the past. So saying that, I would now like all the panel members, if you have a short, quick take-home message, we are here to listen to you. Dr. Arun, you can start, please.
So, in a simple words, prevention is better than the detection of the disease. So always try to go for the screening if you're falling in that risk category.
Right.
Go for the screening and try to detect the disease as soon as possible, so that you have the best possible chance of controlling it.
Thank you, Dr. Qasim.
So at the end, I can say to every sexually active woman, this is your chance. If you didn't start your cervical cancer screening yet, please start it now. It's easy, simple, and it can save your life.
Thank you. Dr. Virishka.
Just one thing, defeat fear, we defeat cancer. Thank you very much.
That's the word, defeat fear. A lot of people are fearful, and today with all of you on coming up and talking about it, thank you. I'm sure a lot of people are relieved. Last but not the least, Dr. Fatma.
I want to say that practicing preventive medicine is considered the highest and the ultimate level in any facility that can reach. And here in the Prime, we are oriented to practice such a service. We are here for you to listen to your fears, discuss your symptoms. Don't feel afraid. Come to us, and we are always available for you.
Thank you very much. One last thing, all our physicians are available in Prime Hospital and in medical centers. Time to time, they might be attending other patients because they go to different areas to cover those neighborhoods. So the best thing would be to call or check on the website and or send us an email, send us queries, and we'll be happy to answer them. We can book you with these physicians. You can use the Prime app. Prime Health has launched a new app which is very simple to use, very easy. You can see the link there. We can send it to you. You can load it, install it on the iOS, Androids. And thank you, all of you, once again. I wish you all a very good health, and may God keep us away from all such conditions. But thank you very much for coming on to this program today.
Thank you.
Thank you, Dr. Mahmoud.
Thank you.